Thank you so much for having me. I have a list of Austin barbecue spots I wish I would be going to this evening, but I'm sorry I wasn't able to make it. Our plane was canceled. So um, I have a couple disclosures, no financial disclosures, but I think it's important to let you know I'm in the pocket of a couple fat cats. This is my life here, and who drives the ship for me. And if I give them the wrong food, this is what I face in the morning as I'm trying to get out of the car. So no financial disclosures, but I'm going to have a little fun talking a little bit about mild cognitive impairment and evaluation of patients clinically. This is where I work. This is the building I'm sitting in currently this morning. This is the Lulu Center for Brain Health. It's located in downtown Las Vegas. It's a Frank Gehry designed building, so only in Las Vegas would you have a dementia center that looks like this. And around for about 12 years. We're part of the Cleveland Clinic, but the only thing we do in Las Vegas is neurodegenerative diseases, and really focuses on both the patients and their caregivers. We have a model that's supported by both philanthropy and some research grants, but we're an insurance-based Medicare facility, and we see patients with three conditions: MS, movement disorders, and cognitive is our biggest department here. My practice is primarily seeing memory patients that are over the age of 55. We kind of have this hybrid academic clinical model where we're seeing patients within a 45-minute period. So I'm seeing about 10 to 15 patients a day in memory, which can be challenging. I have some research grants that I'm working on, including some of the large longitudinal studies that are used to follow patients with Alzheimer's disease. And we have actually a really interesting study that's enrolled over 800 professional boxers, and we've included some rodeo riders as well in that study to examine the effects of repetitive head trauma, and have some clinical trials related to treatment of MCI and Alzheimer's. So that's a little bit about my practice, and what we're going to talk about today is how do you have a good approach to seeing patients in the clinic that are presenting with cognitive disorders. It can be a bit of a challenge to sort of have a straightforward approach, because there's a lot that you can be presented with. I'm going to talk a little bit about the diagnostic tests that are currently available and the ones that we rely on. And we're going to discuss just briefly the prognosis of MCI and early dementia. It's a mess. It's hard to give patients a prognosis. The research data on this is very mixed, and so we'll talk a little bit about that and how we sort of conceptualize that. And how do you talk to families about this? Because I think that's what they're really interested in. This is a case. This is the typical case. This is the dream case that you get. You get a patient, and maybe they're with their spouse, and they're really cute, and they're talking about short-term memory loss, and it's relatively straightforward. But this is the reality. These are not the typical cases. These are not the challenging cases, but it's sort of revealing. So you guys can read the case later, and I know there's a CME question related to that, but I'm sort of give a framework about how to apply it to the easiest, so you can apply it to more challenging cases. So I'll go into that in a little bit. So this is me in sort of residency. If I have a memory complaint, I mean, this is kind of the challenge. You see this on the list of patients you're going to see today. Memory. This used to be my response, and it still is my response sometimes. Is what are you going to find as you open that door for people that are coming with memory complaints? And I think of two situations. Oklahoma State play. They have the Bedlam series, right? What is Bedlam? Where did that come from? Well, it's St. Bethany's Hospital in London in the 1800s. It was a psychiatric hospital, and I've certainly, even yesterday, opened the door, and this is what you find. You find 2 or 3 family members, each has a different agenda, and the patient in the middle that's trying to defend themselves about, I don't have a memory complaint. So how do you handle this? How do you sort through this so you have a very reasonable approach to this situation? Because this is what we find in memory disorders. This is the situation a lot of the times. How do you get out of Bedlam? And the other situation you have is you have these folks that come in and they're maybe in their 30s, 40s, and 50s, and they're bringing bags of medicines and supplements. They said, "Hey doc, what's with this study I was just reading about? I was watching Dr. Oz the other day, and And I said, what about this supplement? And how do you sort through this? And how do you talk to patients in a way that's meaningful, that's, that doesn't lead to a lot of burnout, and you can sort of have a good approach to patients, because I think the evaluation of memory disorders can be really interesting, can be really intriguing and fun if you do it in a way that sort of makes sense. So what do a lot of people do? They throw their hands up and they take a sort of history that may not be rigorous enough to really get to the bottom of the cognitive complaint. We talk a lot about memory, but memory is not the only type of cognitive complaint you can have, or presenting symptom when it comes to patients presenting with dementia. So we have to get outside of memory and talk about cognition. And if the time runs quick and you don't have a lot of time, and we have this issue where we're sort of doing a non-standard assessment of cognition. And I know a lot of folks and a lot of primary care doctors just, well, the 3 words, and remember them after a period of time. And then the MMSE, I'm gonna make an argument later about the limitations of the MMSE. And so having somebody around that can help you administer some better cognitive screeners may be helpful. What happens if you don't have an approach, and this has certainly happened to me, is I sort of lose the sort of structured approach to these patients. We sort of this battery of tests that kind of come back and they're not helpful, and we're sort of left in the same situation. There is a standard set of labs and some imaging that we should get, but we should think about what we're doing and why we're ordering it, and tailoring our approach to each patient. And then neuropsychology. How do we interact with neuropsychology? How do you use it? The problem we have is if you don't have neuropsychology readily available and you order it, it can take 6 months to come back, or it can be a year before patients even get back having the results. And you want to know how to kind of interpret those results, because those are very helpful for the framework I'm going to talk about. Academic centers. We're kind of an academic center. I certainly did medical school and residency at academic centers, and working in those as a physician, seeing that the wait times for those centers are long time. So have a good approach. We can sort of treat these patients and give them some at least preliminary answers, or if you have an academic center, to get those patients in so they can participate in clinical trials. And kind of want to avoid some of these tests that are often administered that may not be helpful. In Las Vegas, we have the problem of the first workup for a lot of patients that have memory complaints is an EEG. That's not all that helpful. We even have some folks doing evoked potentials and nerve conduction studies as the first workup, and heavy metal screens. It's not necessarily evidence-based approach to memory disorders in the sort of the general population. These are targeted diagnostic tests. And then we talk about Prevagen, memantine, Namzaric. There's evidence-based treatment approaches, and Prevagen is not on any of those that we see. And memantine and Namzaric are approved for people with moderate to severe dementia. And so that putting a patient with MCI on memantine, there's some evidence that's not helpful and actually can have some side effects, or it can have a negative outcome on patients with early stage disease. So we want to think about carefully what medicines we're throwing patients at. I'm not going to talk about that today. But ultimately, what does this lead to? For a lot of families and patients is a significant delay in their diagnosis, and unsatisfaction with the family, because they really can't get to the bottom of the questions they're asking, or they don't have a clear answer about what's happening. And we know from studies that more than 50% of patients with dementia diagnosis never get that diagnosis, and it's significantly delayed. This is a really well. Before I get to that, what happens when you don't have an accurate diagnosis, or you can't get answers? People turn to Dr. Google and tell them, I have less than 5 years to live. I mean, I've heard this from patients with mild cognitive impairment, or even subjective memory complaints. Have been diagnosed with dementia because the person they saw didn't have a really good knowledge of a diagnostic framework to provide them, and they go online and and we run into problems with Dr. Google. So anyway, this is a really interesting study that was done in the UK, which shows how good a job we do in terms of accurately diagnosing patients with dementia, especially early stage disease and especially rare diseases like FTD. The diagnosis is delayed. It's up to 2 years from the onset of a symptom to the first consultation, and it's up to 5 years to be able to get to the bottom of the diagnosis. And this is kind of, I think, what folks are seeing. This is Alzheimer's disease is very common in elderly populations, and the diagnosis is being delayed. So what are the benefits of a timely diagnosis? I think it's not always clear to us about why it's helpful to patients and families about getting that diagnosis accurate and getting it right. But there's clear evidence to say that the families and patients want to be diagnosed accurately and appropriately, and so I think that's at the heart of this. One of the major things that we're finding at our center about an accurate diagnosis and what it does is it helps prevent crises. Families that understand about dementia are less likely to seek care in the emergency room, more likely to kind of understand and negotiate the symptoms that come with dementia, like Lewy body disease, hallucinations that may emerge, or REM sleep disorder that comes in the night, that they will less likely to seek acute care if they've been given a diagnosis and have some understanding of the disease, and they can go research themselves about the disease. We talk about adjustment and family support, participation in clinical trials. That's all really important. Advanced planning it is also very helpful for families to sort of get in front of any issues that may come down the line in terms of placement and the need for services. And it's a national policy to come up with a timely diagnosis. We owe this to our patients. And the question about what is a timely diagnosis is unanswered, but the national policy is we need to give patients the diagnosis as soon as we can. So this is all the preamble for a discussion of what I do and how we can kind of do it. And so my argument is to have a repeatable, evidence-based plan and approach to the patients with cognitive concerns, and then apply it to each patient. You're going to apply it to the Bedlam situation and apply it to the polypharmacy supplement situation. And it's important that it's efficient and it's flexible. And I really encourage providers to avoid diagnostic and therapeutic nihilism. It's really easy to say, well, it's just Alzheimer's disease, or it doesn't matter, or these things. It does, and there's a literature of evidence to say that an accurate diagnosis, especially staging the disease right, is very important, and it's very helpful for families. And to accept the situation that our diagnostic methods are not great. They're getting better, and our understanding of the biomarkers that lead to Alzheimer's and other dementias are improving. But even at the most highly specialized centers, when we look at autopsy in terms of the clinical patients, and we look back, the accuracy rates, even at the most select centers, are still ranging between 50 and 70%. With biomarkers like amyloid PET scans, we're getting closer to about 90%, but the diagnosis is still a challenge in this field. This is the NIAA framework, and this is kind of what we're going to walk through over the course of the next couple slides. And it's an old framework. It was developed in 2009, but I think it's still relevant. I think it's easy to stray from this framework, but it's important that we sort of come back, because there's a lot that we can do in terms of providing an accurate diagnosis and sort of conveying to the patients, and also building our diagnostic approach and the diagnostic tests that we're going to order for patients. So we'll walk through this in a little bit more detail. So this is my mantra when we see patients with cognitive complaints. Two things. We want to evaluate the cognitive complaint in two ways. What is the nature of the cognitive complaint, and how severe is the impact? Those are the two important things we want to get done in the first visit. Now, even in the Bedlam situation, we want to get to the bottom of what is the nature and how severe is the impact. And then that feeds into the NIA framework. All these arrows going everywhere, leading to different steps. I mean, this is the bottom line. This is what we need to get to when we're seeing patients with cognitive impairment. And so once you answer these two questions, you can tailor the diagnostic workup much more successfully if you know these two things. And so, yes, there is a standard battery of AAN recommended diagnostic tests that we get in everybody with a cognitive complaint. But we want to do better than that. You can do better when you know what the nature of the cognitive complaint is and the severity. And so that's my argument. So that's the mantra. What is the nature of the cognitive complaint, and how severe is it affecting the patient? And so that requires two things. One, you need to get a history from a knowledgeable informant. That can be the patient. Patients with mild symptoms, you can ask them, do you have a memory problem, or what are your cognitive symptoms? But once we're starting to get down the sort of road of severity, you really need to get the history from a knowledgeable informant, because they will provide much better information. And you have to also evaluate the participant. Do they know the patient? That's one of my first questions when I'm asking a spouse, how long have you been married? Because I've run into this situation where people have been married for 6 weeks, and all of a sudden there's a lot of problems. And FTD, as we sort of see, a young onset clinic, we say young people that don't know each other very well are often evaluated for FTD because there may be underlying personality issues, or they may be on the autism spectrum. And so they will often kind of mimic FTD, and that's one of the sort of misdiagnoses is a participant that doesn't know the patient very well. So we need that information from a knowledgeable informant. Alzheimer's disease has a high degree of anosognosia. Most patients with Alzheimer's don't know, don't care that they have the disease. It's just part of the disease. You have to get information from somebody that knows the person well. And the second part is you need to perform a cognitive assessment of that patient, whether it's sort of a global screener or it's formal neuropsychological testing. This is important, and to build into your practice the ability to get some formal assessment during that first visit. It's very important. I know the 3 to 5 word recall is easy and you can apply it, but it's not helpful information in the way that a standardized, validated screener assessment can provide to you. And I think it's important as we're seeing patients to understand that up to 50% of patients that get to memory centers, so they've been through the tertiary care process, have normal cognition. So there is a lot of issues around getting to the bottom of this worried well situation. So a lot of memory patients that present for cognitive disorders may have subjective impairment, and there's a literature that says that those patients with subjective cognitive impairment may be at higher risk for conversion later down the line, but we don't really know how to approach those patients quite yet, and they're being studied in several different studies. But this is a reality of the situation. A lot of people that are presenting to memory disorder clinics may not actually have a cognitive issue. They may have a psychiatric issue. They may have other issues going on. So it's important to know. And then it's important to know what's the difference between normal and abnormal, and to tease that out. I think that's what our neuropsychology colleagues can be very helpful for, and that's what we rely on them a lot for, because that makes it different in the prognosis. So normal aging causes some decline in cognition, and this is well understood, and it has been validated in prospective studies. And then we see 3 things that can sort of change in normal life, right? That's mental speed, learning on, so for example, a list learning task, and multitasking and some abstract reasoning. So these are the things that are part of quote unquote normal aging, but they may present to the memory disorders or they may present as a memory complaint. And they show up in daily life as maybe some word finding problems. Folks will often say, I can't remember the names of familiar people, but it comes back to me later. I go into a room, I forget what I'm going for. And at work, maybe there's a new technology and it's a little bit harder to learn, or it's hard to learn the new iPhone or whatever. That can usually safely be drawn into the sort of umbrella of normal cognitive aging. And for those patients, what their experience, their subjective experience, may be completely normal and part of normal aging. So it's a good sense of knowing what kind of fits into the framework of normal aging, normal cognitive changes over time. And people with these cognitive complaints may be at higher risk, but we're not really sure. But they certainly aren't the folks that need to be put on cognitive enhancing agents. And so one of the things that I've learned over the course of my time here is the attended alone sign. This is my first clinical pearl. So this is a consecutive series of 726 patients that presented to a UK memory disorders clinic. And what they found was 0 turned out to have dementia. That sort of makes sense. But very, very few had even MCI. And so it's important, this is sort of an important first step, you can say, is the patient alone? If they're alone, it sort of pushes us more towards saying maybe this is subjective cognitive impairment. I've started to learn that the attended alone sign may not apply when the family spouse member arranges the appointment and drops the patient off. So the patient may be alone in the room by themselves, but they certainly did not usually set up the appointment alone. So I've been here 8 years. I've probably seen several thousand patients over the time that I've been here. And I've seen one patient who came alone that I ended up having Alzheimer's disease, and it was a PhD from Harvard University that had, a lot of cognitive reserve, and they ended up making sort of their own appointment because they had some concern about their cognitive impairment, but they did get lost on the way there. So the attended alone sign can be helpful in determining the severity of the cognitive impairment. So this is just something that a clinical pearl that can be taken alone. So if the patient arrives alone, kind of think about maybe this is somebody that's in more of the subjective cognitive impairment range. Another thing that's helpful is clinical pearl number 2 is identify the head turning sign. The head turning sign happens right after you introduce yourself and you get into the question about the complaint. And the first knee-jerk reaction is turn to the person who brought them here. So why are you here to see us today? If you see this head turning sign, it can be very helpful in determining maybe there is a neurodegenerative disease process, and maybe this is sort of getting down the road to looking at Alzheimer's disease or Lewy body disease, where this head turning sign was sort of evaluated in the clinical practice. So these are kind of fun little clinical pearls that have been supported by the evidence in consecutive series in memory disorders clinics that can be helpful. I mean, busy practice, you're seeing 20 patients a day. These things can be helpful in determining who really needs our attention and focus in terms of making a big impact on our diagnosis. So information from the informant, I think we mentioned it before, is crucial. It's often hard to obtain, especially if there's a degree of anosognosia and it leads to a lot of conflict in the room and sort of depending on the dynamics between the patient and the spouse, or the patient and the children. This is hard to obtain, and so we try as best we can in my practice to have some ability to obtain information separate from the patient, whether that's during the visit, whether that's a written report or sort of a handout that may be mailed to the family to sort of fill out beforehand. I think the functional activities questionnaire can be helpful. There's something called the Alzheimer's questionnaire that's sort of a very quick 20-question checklist that family members can fill out, and that can be helpful to inform. Oftentimes, if the dynamics are such that the patient has developed a lot of behavioral problems, irritability, or aggression, you may not get the full history because there's some fear there. And so it's important to obtain this. This helps us inform that issue of the severity of the nature of the cognitive complaint. It also helps us about the nature of the cognitive complaint. There are some good screeners out there. I would recommend if you have the time to maybe mail the FAQ or give the FAQ to the family member while the patient is maybe doing one of the cognitive assessments, the brief cognitive assessments you can do in the clinic. But this is helpful. You can also interview the family and have a standard list of questions you may go through. But having information from the informant is crucial in terms of getting that accurate diagnosis. It's important to understand that dementia requires, and cognitive impairment requires, a change from a baseline. So our definitions of dementia require a progressive change, but also a change from baseline, and that's highly dependent on education level. We know that folks that are less than 9th grade education level and didn't quite go on to high school, and there's a fair amount of them in this age population, may score significantly different on cognitive tests, both on bedside cognitive tests as well as formal neuropsychological testing. So it's important to understand, is this a change, and where they are educationally in terms of interpreting the results. So just sort of a point. And there may be twofold difference, and this has been validated in prior neuropsychology studies, so it's important to think about that. And these are some of the questions that I've found helpful in terms of determining the change, the severity of the change. Are they driving? And if they're not, and it's inquire a little bit more about what was the time, when did that stop? When did they stop driving? And be kind of that kind of can be a benchmark for change. Things like managing medications independently, paying bills, cooking and cleaning. These are questions we all know. But this is a question that one of my colleagues, Jim Leverance from the Cleveland Clinic, finds to be very helpful in terms of informing the severity. Right? If the patient was left alone for a week, what would you be worried about, or could the patient be left alone for a week if you had to go tend to asking a spouse, if you had to go tend to an issue, could you leave the patient alone for a week, and what were the things you'd be worried about? And that can help fill in the gap of what's the severity and the nature of the cognitive complaint. These are the things we kind of get to in terms of cognition, right? So we focus a lot on memory, right? What's the memory? But cognition can be broken down into several domains, and that's what the neuropsychologists are really good at. But you can get a sense of that in a clinic visit. I've had the issue of talking to families and saying, is there a problem with memory? And the family will say, no, there is no problem with memory. And the patient has an MMSE of 20 and is moderately demented. And I said, how does that make sense? Because memory, it can be broken down into sort of episodic and retrograde memory. What we're talking about primarily in dementia is the anterograde memory, the ability to form new memories. And families often don't know the difference. And so we find, patients who have Alzheimer's disease, oftentimes their memory gets way better for things in the past. They live in the past, and often that's interpreted by families as saying their memory has actually improved. So they may answer negative. Does this patient have a memory problem? They still think it's 1970, but they can remember everything about the past. So it's important to distinguish between anterograde and retrograde memory. And these are dementias are primarily disease of anterograde memory going forward. So that's important to think about. Executive function, and we kind of know this. Language and sort of around speech interactions. That's important when it comes to diseases like FTD and frontal temporal dementias and the primary progressive aphasias. So I get a sense of that language ability. That's, often don't think about that as we're going through a busy clinical life and we focus so much on memory, but language is something to get a sense of. And visual spatial functioning, particularly in the young onset dementias, we can see significant and early impairments in visual spatial function. So, for example, I just saw a patient this week, a 55-year-old woman, and her first symptom was sort of pumping gas, could not get the nozzle into the gasket. This woman was still working at the time. So going beyond memory, I think, is important. Behavioral changes. So new frameworks for MCI incorporate behavior, so behavioral changes and sort of changes from baseline. And we know that these behavioral changes may often anticipate cognitive changes. So a lot of patients, there's good work on this from ADNI and the sort of NAC data sets, which have followed patients for long periods of time now and started with cognitively normal individuals, that things like irritability and agitation may be the first presenting symptom of Alzheimer's disease. And so it's important to get a sense of behavioral changes. Hallucinations. I would always ask these questions directly, because there's been a long period of time where I said, well, there's any behavioral changes, anything odd, anything unusual? And the family say no, and the patient says no, no, no. And then you get to at the end, and you say, I forgot to ask about hallucinations. They said no, so I probably don't have hallucinations. And you ask, oh yeah, they've been hallucinating for 5 years. So it's important to be very direct about hallucinations and distinguishing hallucinations from delusions. Hallucinations are very common in Lewy body disease. And say to the patient, do they see a person in the room? Do they actually see a person? That's a hallucination. A delusion is a fixed false belief that a person has encoded into their sort of worldview. But they're slightly different. A delusion is really about a patient's feelings. So they may say, well, there's a person in the house. Do you ever see them? That's a delusion. A hallucination is actually the visual, can be in multiple modalities, but the actual sensory input that is actually happening to them. So visual hallucinations are very common in dementias, whereas auditory hallucinations are much more common in primary psychiatric illnesses like schizophrenia. And it's very, very unusual, very almost unheard of to see a patient with Lewy body disease having auditory hallucinations. It's primarily visual hallucinations, and that can kind of steer you in that direction. And then for FTD, the behavioral changes are very prominent early, but they're distinct changes. So behavioral variant FTD is not grumpiness, it's not irritability, it's severe changes in disinhibition, food preferences, and apathy. So, we kind of say everything could be FTD because their behavior is changing, maybe exaggerating underlying personality traits, but FTD is a very distinct syndrome, and it has very, very unique changes in behavior. So that it's important to get a sense of behavior. Okay. The sort of bedside tools that we use, there's a bunch. These are important, and I think they need to be part of the sort of everyday evaluation of patients, and we kind of know what these are. But I think there's a heavy reliance on the MMSE. We know that the MMSE was developed in the 70s primarily in a hospital setting for delirium. And so it's really based on, there's a lot of attention and focus, and it's heavily weighted toward language. And in Alzheimer's disease, language is one of the later cognitive domains. It sort of comes in the mild dementia stages, so you can miss dementia. This has very poor sensitivity and very poor specificity for MCI and dementia. So I try to avoid using the MMSE. And so this is an example of a patient with an MMSE of 25. Seems like he's doing pretty good. Same patient is administered the MoCA, and we see the story changes significantly because the MMSE really doesn't have any real strong executive function components to it. And if we're dealing with Lewy body disease, as we are in this patient, where the prominent cognitive feature is executive, you're going to miss that on the MMSE. So I tend to use the MoCA as a screening tool, and it kind of introduces a level of insight that you can glean right from the cognitive test that you can't get from the MMSE. It's fast, it's cheap, it's easy to administer, and what I really like about it, it gives some insight into the nature of cognitive. I think this is the fun part of cognitive neurology or behavioral neurology is getting to the sort of what's happening within the brain and seeing these sort of dysfunction in these cognitive systems. For example, there's data showing that clock drawing is very abnormal in Lewy body disease. And so this is an example. This is just the past month of some of the clocks that I've seen in patients with Lewy body disease. And we can see there's poor planning, there's a sense of unusual drawings, there's like a semantic knowledge loss that comes into clock drawing. And all of these patients ended up having Lewy body disease. And the difference is then they can get to the bottom of the test and they're actually pretty well oriented to date and month sometimes. And so sort of looking at this executive function can be helpful. As opposed to folks with Alzheimer's disease who have a anterograde memory problem and they have an encoding problem, so they don't store new memory. So how this shows up on the MoCA is an inability to remember even with cues. And so the MoCA is helpful to go through the whole experiment or exercise of getting to the category and multiple choice cue, because that tells us about the nature of their ability to encode. And so when we see patients with Alzheimer's disease, the impairments are going to be at the bottom of the test, right? They're in the delayed recall and the orientation part. So that can be helpful, and that helps distinguish Lewy body from Alzheimer's disease, sort of the spatial arrangement on the MoCA in terms of the impairments. And then FTD, we kind of go through those animals in the middle part of the MoCA, can be helpful in terms of their semantic knowledge ability. So looking at the giraffe and saying, I don't know what that is, or it's a dog or something of that nature, or the clock drawing where there's just really far off and sort of not even a clock itself. And this is an example of somebody with primary progressive aphasia, semantic dementia, that was able to draw the clock. So you can glean a lot from the Montreal Cognitive Assessment. So looking at the MoCA here, this is a patient with mild cognitive impairment due to Alzheimer's disease. Their impairments are at the bottom of the test. This is a patient with FTD. The impairments are with the naming abilities. They called the lion a dog, and they didn't have an attempt on the rhino. And then the word generation. So word generation in FTD, the F word fluency is often very, very low, significantly. We're talking about 0 to 1 to 2 to 3 words. So looking at that F word generation. So I like to look at the MoCA not only quantitatively, but qualitatively. And then we talked a little bit about clock drawing in Lewy body disease. And so you may get these funny looking clocks, or you may get these difficulties with cube copying that we see here. So I'm looking to see qualitative, not only the score, but how are they doing on these tests. These tests were validated and developed in MCI populations, primarily with Alzheimer's disease. And so these tests are pretty good about picking up Alzheimer's disease, but they also can catch these other diseases along the way. So this is kind of the fun part for me. So what are kind of adding on to the MoCA that you can do in clinical practice, and I like to do this. I find this to be very helpful and kind of interesting, is the idea of word generation. So we have phonemic fluency, which is related to the first letter of each letter. So for example, you ask the patient to come up with as many words as they can think of in a minute that start with the letter F or A or S. Those are sort of common letters in the generation there. And then you ask them to come up with a semantic topic. So for example, animals with 4 legs. And what we're finding, and what has been shown very definitively, is that those activate different parts of the brain. So phonemic generation comes primarily from the frontal lobe. So in FTD, what we're going to see is very poor word generation, primarily of those, those words we see, 1 to 2 to 3. You might even see 0 word generation in patients with semantic dementia. Whereas in Alzheimer's disease, the frontal lobes are largely spared until later in the disease course. You're going to see early involvement of the temporal lobe, and semantic word generation primarily comes from the temporal lobe. So what you'll see a lot of times with those patients is normal F word generation and then very low animal generation. So you could have patients that generate 20 to 30 F words, and you ask them to generate animals, and they may get 5 or 6. And this has been validated in in studies that looked at the ability to generate less than 15 words in 1 minute was associated with MCI and Alzheimer's disease at very high levels. So that's a quick and dirty kind of bedside test that you can do to kind of help. And I usually use that benchmark of about 15, or use the ratio of F words to semantic fluency to help me with my diagnostic workup. Now, I think getting back to the severity of the impact, I think it's important that every patient that you evaluate for a cognitive complaint be staged in some way, right? And you can use that using functional activities. You can use that with the CDR, which is a longer clinical interview that takes about half an hour to administer, so it's really not practical. But what I like is the FAST stage. This was developed by Barry Reisman in the 80s, and it's developed related to dementia, all-cause dementia, but it kind of stands up to things. And so we often use this FAST stage, and this is often very helpful to give to families to help them kind of understand where they are in the disease and where it may progress. And it's also helpful because it includes normal aging and includes subjective cognitive impairment. So I often find giving this to patients is very helpful. But it's also helpful in terms of framing where they are in the NIA criteria and to order the appropriate diagnostic testing. So I find the FAST stage to be incredibly helpful in clinical practice. So now we know the nature of the cognitive complaint and we know the severity of the cognitive complaint. Now we're sort of into the sort of diagnostic workup. What's the diagnostic workup? There are inflection points along this NIA criteria that was developed in 2009. And really, there are two. One, is it normal and abnormal cognition? And is it dementia or MCI? And so that's important in terms of prognosis, as well as ordering the right tests. And really, this framework revolves around memory impairment. And that's important to get a sense of is memory involved? Are there other cognitive domains involved? And where are they in the sort of staging? Because it makes a big difference. This is kind of related to the fact that Alzheimer's disease, we think, is on a continuum that starts and follows a sort of natural progression. Where this is most helpful for, as a provider seeing patients, is when folks are outside of this framework. If they're not following in sort of a sequential nature of what's going on, it can be helpful in terms of ordering additional workup. So if you have, for example, a patient that's stage 4 dementia, Alzheimer's disease, and they develop urinary incontinence, at that point, we can likely assume that there's something else going on. And so that helps clinically as well. So it's important to frame patients in terms of where they are in the severity, that they're following a natural pattern, and where they are at the time of diagnosis. And I think the NIA framework revolves around amnestic versus non-amnestic, and then we get into these other domains that could be helpful in terms of determining the diagnosis. We know that people with MCI, and this is over time, this is what's really kind of come out of the literature over the past 20 years, is MCI is sort of an inflection point where patients have some variability in what direction they go. Many patients with MCI can revert back to normal, but once patients reach the dementia stage and you've accurately diagnosed them and staged them, there is no reversion back to MCI. Dementia typically progresses, and we've reached a threshold of neuropathology which there is usually no recovery from. MCI is a different situation, and patients can go back and forth in terms of reverting back to cognitively normal or progressing to dementia. So it's sort of this important point. Likewise, the distinction between subjective cognitive impairment and MCI is also important. And it's hard to distinguish, and that's where I think neuropsychology can be very helpful. So patients where you think about subjective cognitive impairment, MCI, neuropsychology can be very helpful. And as I mentioned before, once we reach that stage of mild dementia, there's very little chance of reversion, and there's a high likelihood that we're dealing with a neurodegenerative disorder. And it's not, MCI is a stage where maybe there's other possibilities of multiple comorbidities or stress or anxiety or depression, but those those things cannot generally cause a level of functioning of dementia in general. I mean, severe depression may cause sort of a stage of, look like that stage of stage 4, but once we reach stage 4, we're really thinking that they're neurodegenerative pathologies. MCI, in clinical practice, that's where you want to look for other things like obstructive sleep apnea, the effects of polypharmacy, and those as the major causes of their cognitive impairment. So now we have sort of a sense of what's the nature of the cognitive complaint and how severe it is, and then we sort of work from that framework to get the diagnostic workup. And so, everyone deserves a basic lab workup and recommended TSH and B12 and CMP, as well as some neuroimaging. And some patients, if it's available, neuropsychology can be helpful. But neuropsychologists aren't diagnosticians, and they produce a report that we have to interpret within the framework of the NIA criteria. And so it's helpful to understand what the domains they're checking and to understand how that fits into the NIA framework. So if you have impairments in a single domain, the patient will meet the criteria for MCI. If they have multiple domains, they can still be MCI, but dementia requires 2 domains. You have to have impairments in 2 domains to make a diagnosis of dementia. So if we're only looking at one domain, by definition, patients are in the MCI framework, and we can think about other things that are going on. Once they have impairments in 2 domains and they're functionally impaired, we're thinking, again, this is neurodegenerative in nature. As I mentioned before, MCI can be multifactorial. It's highly prevalent in the population. And for these folks, we want to cast a wider net. We want to look at other things that may be impacting their cognition. Obstructive sleep apnea as the primary cause, multiple medical comorbidities, other things of that nature. And so for this group, I'd cast a wider net and look for reversible causes. And then this is some data showing that the sort of severity of the cognitive impairment with biological markers of disease can be helpful in terms of determining the prognosis. And I think amnestic MCI is really the hallmark diagnosis where we look for these biomarkers to help us stage out the disease. And we know that amnestic MCI doubles the risk of AD compared to non-amnestic MCI. So if you get a neuropsychology report back that says as a non-amnestic MCI, we can start thinking about other things potentially contributing to their cognitive impairment, and the prognosis is much better than dementia. And so what's new in the last 3 or 4 years in Alzheimer's disease is primarily research frameworks. And we're talking about biological markers. These aren't ready for the clinic, but we can obtain some sense of these in our clinical practice. But this is the ATN framework that's been developed for Alzheimer's disease. We've moved from Alzheimer's disease to being primarily a clinical pathological diagnosis to completely a biological diagnosis in this framework. And people that have amyloid in their brain are on an Alzheimer's disease spectrum. And then it's when you add other biological markers on, then we kind of sort of get diagnostic certainty around Alzheimer's disease. So this framework is newly developed. It's currently being validated, and research studies are helping us. But what we're finding is that even with biological markers, our ability to predict course in Alzheimer's disease is very challenging. This is my final clinical pearl about what we can use in terms of looking at signs of Alzheimer's disease and the sense of the biological markers, and that's hippocampal atrophy. And so we can visually see it. There's some visual rating scales that have been developed around hippocampal atrophy, but this sort of gets us a sense of looking at Alzheimer's disease pathology. And there are volumetric analysis abilities and companies that will analyze MRI scans and kind of produce a report around hippocampal atrophy and other brain atrophy. And if we're looking at non-amnestic single or multi-domain MCI, that's where we can go to a PET scan. And a PET scan is available through CMS It's indicated for the use of when the differential includes FTD, and it can be helpful for particularly non-amnestic single or multi-domain MCI, and it can give us a sense of if we're dealing with something like Lewy body disease that shows up with a cingulate island sign, or FTD where we see frontal hypometabolism. So when we come to prognosis, I think the state of the field is still in flux. Even with the best biological markers, we still cannot predict course in Alzheimer's disease and dementia. And this is particularly true in other dementias where there have not been large prospective studies. We have several in Alzheimer's disease, but this is what comes out of it, is that the prognosis and the trajectory depends on the individual. And so we think about things like cognitive reserve and comorbidities and their environment and behavioral issues that may be related, and age and education. Those impact prognosis in the disease. And so if we see several different studies that have mapped out trajectories, and it's kind of all over the place. So it's really hard to know, even with the biological markers, that these trajectories cannot be mapped out with a high degree of certainty. So it's really hard to convey this to patients, and the literature isn't all that helpful. But here's what we know. If we make a diagnosis of MCI, we know that there's an increased risk for conversion from MCI to dementia. And we know that the conversion rate over about 2 years is about 15%. And so it's relatively low. So if the majority of patients are going to stay stable, I mean, that's sort of the sense. And we don't have a really good sense of who's going to convert. I think the best marker for conversion from MCI to dementia is tau levels on CSF. But most patients, we don't have that knowledge or that ability. And even high tau levels are not necessarily always correlated with a quicker conversion from MCI to dementia. We know that MCI is a risk factor for dementia, clearly, but the reversion in MCI is still rather high as well. So our ability to prognosticate in MCI is challenging. This is sort of the framework around the biomarkers, the biological markers of Alzheimer's disease, and a lot of them reach a period of stability by the time of dementia. So we don't use biomarkers to determine disease prognosis. They're not prognostic markers. And so repeating MRIs and things like that are not that helpful. Repeating CSF analysis is helpful diagnostically, but it's not helpful prognostically for most cases. The best staging we have in cognitive disorders is still the bedside cognitive tests and the neuropsychological testing. So we need to develop better biomarkers, and we're heading in that direction, but it's still a long way away. So this is just a little bit about prognosis and the risk of conversion, and we're really kind of all over the place. The studies range from 5 to 50% in terms of determining the conversion from MCI to dementia. So it's a really challenging place to be as a clinician. There's been some studies that say older age, ApoE carrier, being a male, having higher tau levels are associated with increased risks of conversion. But in this study, where they sort of looked at prognosis and disease duration, they found that in patients with Alzheimer's disease, that was actually longer than the residual life expectancies of non-disease states. So even the studies we have are sort of hard to interpret, because we know that these diseases sort of impact lifespan and life expectancy, but we're using the studies like these to sort of determine it's not that it's helpful. So I think here's a helpful guideline. I would avoid definitive prognostications about disease duration. I would use the FAST stage to help educate families around it. And I think I would be honest about the field's poor prognostic abilities. Patients will often, and family members will often grab me and say, how long is this disease? Where are we at? And it's hard to predict. And I know I've been on the receiving end of folks that have been given 5-year life expectancies and things of that nature, and that's not helpful. I point them toward the FAST stage and say, this is where you're at, and this is maybe a good framework for thinking about things like long-term care and the need for help in the house and things when that's going to be necessary. So there are no prognostic biomarkers. We're looking at diagnostic biomarkers solely in Alzheimer's disease in the field right now. So that's a challenge, and it's something that the field is working toward getting around. I'd use follow-up visits and regularly scheduled appointments to track a time course over time, and that's usually most helpful clinically. And then finally, I think a paper that was published in just recently talked about incorporating this X factor. This X factor is an unknown factor. It's genetic. It could be a genetic factor. It could be a cognitive reserve factor. It can be the effects of other things that are unknown that impact sort of the framework for how we think about Alzheimer's disease. And it's not simply the ATN research framework that's been developed that's purely biological based. We know that humans are completely different, and there's other factors that may be at play, and those are not currently incorporated in research guidelines. So it's a challenge as a clinician in the field for prognosis. But I think in terms of diagnosis, we can do a better job at the bedside and in the clinical visit in terms of getting our patients into that NIA framework and then ordering tests that may be helpful going forward. I'm sorry, I'm running out of time. These are my selected citations for this talk, and I guess I'll take some questions if we have time.
Fantastic. We have a couple questions online, and then we have an audience question.
Yeah, Dr. Ritter, thank you for your talk. I was wondering if you could briefly talk about your steps in the diagnosing or differentiation between cognitive impairment with NPH versus early amnestic, and what type of criteria for NPH do you use, the steps to turn or just the imaging as far as making that diagnosis?
Oh yeah, so NPH that's a talk in itself. That's a great question, and it's been somewhat plaguing my mind because it's always the one thing that we're worried about we're missing, right? And so we know that in terms of response to shunting, the best measurement is the motoric function. So we really, if we're thinking about NPH, we really focus on the motoric aspects and less on the cognitive. I think it's best to have a multidisciplinary approach to NPH because that's a disease and an entity that really we struggle with unless there's a multidisciplinary. So we involve the movement disorders folks. We have very strict guidelines in terms of measuring steps to turn, and that's what's going to respond. The cognition, there's very limited evidence that shunting will improve cognition.
Thank you. Can you comment on new potential or approved therapies for degenerative diseases such as antisense oligonucleotides for Huntington's disease? And then I'll follow that with a second question from the chat that's kind of similar. Can you provide your opinion on the amyloid antibodies? Are you using them, and how do you select?
Sure, that's a great question. So it was disappointing. I think sense nucleotide treatments for Huntington's, we have a failed trial recently in a phase 2 study that was negative. So it's very disappointing because it's a very promising therapy, and I think they're on the way. They're hard to deliver, so we have to deliver them through infusions, CSF infusions. So we'll see how that goes. The issue around aducanumab and the other two compounds in that class is challenging. Recently, CMS determined that they were not going to cover. So we had started a program where we were taking a sort of a multidisciplinary approach to these therapies. That's been thrown into issue with coverage. So the coverage issues, I think the determination will be made in April, kind of revisit that. The statistical data is not really in support of a definitive outcome for those folks. So I think more study needs to be done. Biogen and hopefully the CMS will initiate a large phase 3 clinical trial that will provide some answers. But at this time, I would not recommend those for patients in clinical practice.
Okay, thank you. I think that's it, and we're out of time.